Okay, welcome everybody. Can you hear me okay in the back? Great. Great, well welcome for those that are live streaming, welcome. Those in person, welcome. I hope you're enjoying the books we were able to provide, the appetizers and some of the drinks. And it's really great to have you all here. We do this quarterly here at BlueWave Medicine. This is what we call the Evolve series, where we're helping ourselves and you all evolve into even more beautiful human beings. So we're fortunate enough to be able to do this here at Cavallo Point Lodge, which is a gorgeous facility, and here we are finally enjoying summer. So summer's here in full stride. So it's great to have you guys all in person. Nice to have you guys live streaming. And so today we're focused on brain health, and we're fortunate to have Dr. Dale Bredesen with us. And I'm going to start a little bit just by providing an overview about brain health in general and about BlueWave Medicine. So without further ado, I'll get started here. And I'm really happy to say that we're at BlueWave focused on precision health, which is why I'm so excited about Dr. Bredesen's work, what he's been leading really this whole era, this whole domain around optimizing health. As some of you guys know, he wrote a book called The End of Alzheimer's, and his latest book that we have been handing out is called The Ageless Brain. And I can tell you, when I was in medical school, and I was at the finest of institutions, we basically were told when you're 20, that's it. That's basically all your cognitive development, and from then on, it's you know, good luck. And also, there's nothing you can do if you start to have memory loss, right? So, and there's no good drugs, by the way, either. So, if you want to become a neurologist, good on you, but it's not the most optimistic profession. I think Dr. Bredesen's showing us that that's changing a lot. So let me give you a little bit of an overview. At BlueWave Medicine, some of you are members, and those that aren't, I'll just speak to the fact that we do concierge medical care. We focused on precision medicine, meaning that you're an individual, you have your own experience in the world, you have your own genetics, you have your own risk preferences and tolerances, and so things act differently on you than they do at the population level. And much of the research that we do is population-based, right? We do randomized controlled clinical trials, and they require a large population. And we randomize you to one group or another, and then we average the group. And we compare that average of this group with this other group over here and see if there are differences. And so it's interesting because sometimes you as an individual may have an amazing response to a particular drug, but it shows that the drug or the medication or the intervention or the lifestyle intervention, whatever it might be, actually didn't work between the two groups. But for you, it might have worked. So how do we figure out the wheat from the chaff? How do we figure out what works best for you? So in part, that's the journey. When we think about this, I love this slide because it tells you that there's hope, that even though you're older than 20, all of you in this room, you still have the possibility to grow, to change, to learn, to expand what's possible for you. And I like this slide. This happens to be my son from like 15 years ago or so, because our minds, we can still be the young child. We can still be curious. And that growth mindset allows us to continue to learn and to actually not have things that wane only, but to pick up new hobbies and try new things and try new ways of being in the world. There's a few ways to look at it, and this gets a little bit more detail-oriented and data-driven. The highlights are there's great diagnostics. You can actually do genomic testing. There's genetic testing like Intellex DNA, by way of example, that looks at 300 different SNPs just for brain health. And there's biomarkers that you can look at too. And Dr. Bredesen will go more into detail around this, that you can also look at. And then there's what you can do about it. And there's a lot of lifestyle things that are possible, in addition to supplements and potentially medications. And you can see here that we know there's good science looking at exercise and different ways of exercising. There's good science looking at meditation, different types of meditation, gratitude practice meditation, and other types. And you don't have to be a monk or spend an hour a day doing it. Literally, you could do 3 minutes 2 or 3 times a day, and that actually rewires your brain. And then what you put in your mouth, right? What kind of food do we put in ourselves? And then, of course, the one that no one talks about, connection. And we are in an epidemic of isolation, right? We're in an epidemic of electronics and digital world. And did you know that social isolation or loneliness is equal to having an ApoE44 allele gene? So you're 3 times more likely to get Alzheimer's disease if you're socially isolated. And that's about equally as potent as having an ApoE4 allele defect, if you will, or mutation. So I think we'll go into more detail with Dr. Bredesen's program. You'll learn a lot in the book. But here's a quick, short list of things that I think are quite helpful. From creatine to reducing chronic infectious diseases like if you have chronic herpes infection, to vitamin D supplementation, to sulforaphanes or glutathione, to a range of different things that are out there that are possible. There's something called piracetam, which is only available in Canada, but there's a range of things you can take by mouth. And if you're looking at genomics, this Intellex DNA, which looks at all these different SNPs, really breaks it down in these different categories of inflammation and brain barrier permeability and detoxification pathways and hormones and mitochondrial function. And then there's these biomarkers that I mentioned as well. So there's really a lot we can do here. And if you look at this case example of a 55-year-old with a family history of Alzheimer's disease, and you can see here that we ran genetics on them, and you can see they were somewhat protective with the ApoE23 genotype, which is actually protective. The 2 is protective. And you can see the ApoE23, which is protective. And then if you look here at other SNPs, and we don't have to get into all these details, but this tells you a lot about what's happening in these different pathways, if you will, mood, detoxification, etc. And then what you can do about it. And the point of this slide is there's stuff you can do. And Dr. Bredesen has a program called the ReCODE program, and you'll learn more about that as we go. This is an example of of a sort of a scorecard, if you will, that you get from running these genetic tests. And the point being that you can learn a lot more. A lot of people are getting their Alzheimer's gene checked, but there's so much more that you can learn, right? By doing this multimodal genetic pathways, look in the biomarkers, have a detailed history, and then engage in a lifestyle program. And let's go to the final slide. So I have this slide here. Really, it's a QR code that you're welcome to go ahead and use your camera on. And this provides a prioritized list of what we just went through on our website. So feel free to click on that. It'll take you to BlueWave Medicine. And we developed a prioritized brain protocol that looks at really what we just went through here quite briefly, because I really want to leave time for Dr. Bredesen to really talk about the work that he does. And just to say that, Dr. Keith DeRoche, who's my partner here in the back corner, he's fantastic, and we're starting a separate focus on brain health. So what we're doing for our existing members now is really having a separate visit to really focus in on, for those that are interested, we can do brain imaging. There's a beautiful group called the California Brain Health Institute here in Southern Marin. They do intense and detailed cognitive assessments. We can do the genetic testing, the biomarkers, and then sit down with you and really talk through what's right for you. And figure out, do we want to drop you into the ReCODE program that Dr. Bredesen offers? Can we manage it ourselves to really spend some time with you and walk through this program individually? So without further ado, appreciate your time here. And I want to introduce Dr. Bredesen. And I've known Dr. Bredesen it's been coming up on, 15 years now. We met originally when he's the founding president of the Buck Institute, which is responsible for really doing a lot of seminal work around aging. And I didn't realize, but you trained and did a fellowship training with under Prusiner, who's the one who involved with prion work, early prion work, and then which was cutting edge for its time, and then has gone on to do a beautiful work with a book in 2017 called The End of Alzheimer's, and now his latest book called The Ageless Brain. So without further ado, thank you, Dr. Bredesen.
Thank you so much, Dr. Brad. So let me just, and thanks, by the way, for just such a beautiful site to be here. I love Cavallo Point. It's a great place. So thank you very much for the invitation. Really appreciate it. All right. Okay, got it. All right. So how many people here would like to avoid Alzheimer's disease? Yeah, so, and how many people know their p-tau217? Okay. So if you want to avoid Alzheimer's, that's one of the things you definitely want to know, p-tau217. How many people know their ApoE status? About, 3 or 4 people. So another thing, again, we're at a time when virtually all of us should be able to avoid Alzheimer's. Strange, 10 years ago you could not have said that. 5 years ago you couldn't have said it. But now things are changing, and I'll show you some highlights today. Things are changing literally month by month. We have better blood tests than ever. We have better imaging than ever. We have better treatments than ever. We have a better understanding of what actually happens in the brain than ever. So it's actually a great time. When I was training, when I was training way back at UCSF in the 80s as a neurologist, we were told, again, nothing you can do if you've got Alzheimer's. You can't really predict it. You don't know what's going to happen. There's nothing to treat it, and it was a real disaster. So I want to show you a couple of interesting things. So this is something new. So this is an arterial. How many people have heard of arterial spin labeling? It's a technique in MR. So you know what MRIs are. You can get magnetic resonance imaging. So when you do that, here's the front of the brain, right here. Here's the back. This is the occipital lobe. This is frontal lobe up here. And this is the same person. This person has what Brad mentioned earlier, which is ApoE4/4, 2 copies. Now, if you have 0 copies of ApoE4, that's 75% of the population, then your chance during your lifetime is about 9% of developing Alzheimer's. It's not 0, but it's not too high. If you have a single copy, and that's 75 million Americans, most of whom don't know it, which is why it's a really good idea for all of us to get checked, because there's a lot you can do about it to make sure that you don't get the problem, get Alzheimer's. And in fact, there's a wonderful website called apoe4.info, who is started by Julie G., who works with us, and she herself is an ApoE4/4. She was already in early stages. She's done great now, and actually wrote part of the second book with me. So she's amazing. So here's another person, ApoE4/4, 67 years old, already had the third of 4 stages. So first stage is asymptomatic. Second stage is called SCI, subjective cognitive impairment. Third stage is called MCI, mild cognitive impairment, and then the last stage is called dementia. The good news, we can pick it up now at the very beginning so that nobody ever has to get the dementia part. So this person was in that third part, which was the MCI, mild cognitive impairment. And where you see red here is where the blood flow is very good. Where you see green is where the blood flow is not so good, and where you see blue is where the blood flow is very minimal. So the hallmark of Alzheimer's disease is reduced flow in what's called the precuneus, which is kind of right here. And you can see exactly, this is a classic MRI ASL, arterial spin labeling. It's measuring blood flow in this different part of the brain. And this is classic for Alzheimer's. So this person, ApoE4/4, has Alzheimer's. It's in that third stage. Here's a year later, after being on the protocol that we developed, and this person was taken care of by Dr. Heather Sanderson, who's down in San Diego. And these images are from Dr. Cyrus Raji, who's a professor at WashU. And you can see here, this is a normal ASL. So this person now is completely normal, actually is asymptomatic at this point, and has a perfectly normal ASL, whereas this one is classic for Alzheimer's disease. So, white spots. Which white spots? Oh, these are places where I'm assuming this is just error. This is minor change here. You can see there's nothing here that's classic. Yeah, so this is presumably something that's not, I don't think this is just more than the others. I think this is just something that it didn't pick up. That's a good point. But this is the key point here, is that this is having very good normal blood flow. So these are the sorts of things that have never been reported before. So we're in the middle of a trial now, and of course, just as Brad was saying, when you say, well, we can help people, you start with anecdotes, 1, 2, 5, 10, 100, what have you, and then the medical community always says, well, fine, we want to see a randomized controlled trial before we'll believe it. Fair enough. My argument is always, what about compassionate use? If you have a disease that's untreatable and you finally have something that seems to be helping, don't you want to get that out to as many people as possible, just as you would with a new cancer therapy, which is what we did starting back in 2012. But we now have a randomized controlled trial. We've published a proof of concept trial in the past that was very successful. So now this is 6 different sites around the country, going from Miami to Nashville to Cleveland to Sacramento to here in the Bay Area. And these are 2 groups, and you can see here, this is group B. These are the guys that are getting the standard of care for Alzheimer's disease. And you can see here what's happening to them, just what we know happens to Alzheimer's disease. And here's the one that is on this precision medicine protocol that we developed about a decade ago. And you can see they're getting better and better and better. And this difference is highly statistically significant. This is interim results, so we'll be finishing this at the end of October. And we're very excited to get this out and published. I'm sure that there will be someone will come back and say, wait a minute, what about you got to raise the bar, what's the next thing, and this sort of thing. By the way, we've compared the magnitude of the effect here with the trials, and the magnitude of the effect here is far, far better than you get with any drugs. And in fact, you may have seen the recent thing from the Alzheimer's Association, which was the U.S. Pointer trial. This was a $50 million trial where they just did 4 things, but they did it for 2 years, 2,000 people. The magnitude of the effect here is 15 times what the magnitude of the effect in that trial was. So it really does matter when you look to see what's actually going on, and you find just the sort of things that Dr. Brad was talking about before. You want to know, and this is what we studied for so many years in the lab, what actually drives the molecular changes in the brain that ultimately lead to degeneration, whether it's Alzheimer's, Lewy body, Parkinson's, macular degeneration, any of these things. So this is just to show what happens when you go on the control and then you switch over to the treatment. And so you can see here the standard of care, people are going down, 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 and these are 3 different tests: executive function, composite memory, and this NCI, which is an overall cognitive score. And you can see this is just from one of the 6 sites that finished early. So they're going down, down, down. They switch over at the end of the 9 months, and boom, they have this dramatic increase. So again, it is something that shows you that, yes, it really does make a difference to figure out why people are having problems and then to target the things that are actually causing the decline. So this is, again, why it's really great that you're part of BlueWave. It really does make a difference where you go. And so what we've been telling people is it's a little bit like surgery. So when you do precision medicine, it's not just write a prescription for the same thing for every person. It doesn't work that way. You really have to look, you have to get the right tests, you have to figure out what's driving it for each person. And so here are the 6 different sites, and you can see 4 of them are getting spectacular results. The other 2 are not. And it turns out that one of these 2 sites has the only doctor in the trial who didn't have formal training in this approach. And it shows. It was not really helping. The other one is the place that has a health coach who didn't have formal training. So it really does matter getting with the right team, like BlueWave, like a group that really knows what they're doing, makes a lot of difference. So the point here is just that we're understanding this like never before, and this is what we spent so many years in the lab looking at. So this is just, this is meant to represent a membrane in neurons. So in your brain, you have this really interesting molecule called amyloid precursor protein. It's a molecule that sticks, it's a protein that sticks through the membranes, especially at your synapses. And what's really interesting about this is it acts like a switch. So when things are good, you've got enough hormones and nutrients and not too much inflammation. Things are good, just like in a country that says, hey, things are good, we're going to build new bridges and things like that. Same idea. So what happens, this thing actually gets cut at a single site by an enzyme, literally molecular scissors, and it generates these two peptides, one for outside the cell, one for inside the cell. And what they do is they basically tell you, hey, grow new synapses, support, you can have learning and memory, things are good, we're going to build. And what we found is really interesting. This is part of a connection set, which is over your entire body. It changes your likelihood of thrombosis. It changes your immune system. It changes how your brain signals. It changes all of these things all together to basically say, yes, we're going to grow, we're going to make new connections. On the other hand, when this same thing sees things like COVID-19, something that's a problem, and if you hit the next one, it'll show this thing gets cut at 3 different sites by different molecular scissors, and it generates these 4 peptides. And interestingly, here's the amyloid. The drug companies are just saying, let's rip this out and maybe things will be better, but it hasn't worked because this is a more complicated story than that. So you now get these 4 peptides, and what they're doing is they're actually going from connection to protection. Very much like a country that would say, okay, we're not going to build new computers and build new bridges, we're going to build rockets and we're going to be protecting ourselves against invaders. That's exactly what your brain does. And again, you can see a whole list of things that all change systemically because you are trying to protect yourself. And guess what? This amyloid is actually a wonderful antimicrobial peptide. So what it does is it kills viruses, it turns out. It kills bacteria. It kills fungi. It kills spirochetes. It's kind of an amazing molecule. And so we've kind of vilified this with the drug companies saying, let's just get rid of it. That's like saying, let's send the cops home. No, sending the cops home is not going to help. We want to make sure that you don't need the cops. That's what we want to do. So when we treat people, we look to see why are you on this side, and then what we want to do is drive you back to this side by increasing the supply, nutrients, all the things that Brad was talking about, and decreasing the demand. And the typical demand things are inflammatory things, various infections and things like that, changes in your oral microbiome, things like that, and toxins. And unfortunately, we've all been exposed to lots of toxins. They're out there. The big one that people are concerned about right now, of course, microplastics. And they're there. And by the way, they are more in the brain than they are in the liver or the kidney. And if you have a higher level in your brain of microplastics, it is associated with a higher risk of cognitive decline. We don't yet know what's cause and effect, but we do know that there's that relationship. So this really is kind of shows you, even though this is at the cellular level, the same thing is going on at the whole organism level. That you've got this connection and protection, so we want to get you out of that protective mode and back into the connection mode and make sure you don't need this one. If you're living in a house full of molds and mycotoxins, you need this side. But unfortunately, it is associated with brain atrophy. So the point is, we have to change our thinking. We've all been in this world where we say there's nothing that can be done about cognitive decline. Doctors will say, don't bother to check, there's nothing that can be done. Oh, by the way, they say you go in and say, well, I'm having some trouble with my memory, and they'll say, oh, you're just getting a little older. I hear this all the time. That is 20th century thinking. We want to get everyone into the 21st century. So there is so much that everyone can do. My hope is that nobody here will develop Alzheimer's. Unfortunately, in the US, about 15% of the population dies of Alzheimer's disease. And I should have mentioned, the ApoE4 single copy, 30% chance, lifetime chance. 2 copies, 90% lifetime chance. So most likely you will get Alzheimer's, but you can do something about it. You can prevent it. You can, especially in the early stages, reverse it beautifully. Okay, so let's just zip through here because there's so much that we can all do and we should be doing. And for most of us, this does represent the difference between life and death. And so we want to make sure to have good cognition, which is why I wrote The Ageless Brain. So we want to have our brain span being equal to our lifespan. So the best thing to do is start early. Find out what your p-tau is. If you're 35 or over, find out where you stand, and then look, you can check every 5 years or so. When you hit 60, you want to check every 2 years. I just had mine checked, my p-tau and my GFAP and my NFL checked a couple of months ago. It was really easy. Had it done at my kitchen table. They can draw the blood, and you can find out where you stand. We work with a group that is actually has the most sensitive tests in the world. Great. I saw that. I was happy to see it was normal, so I will check it again in 2 years. So here, as I say, if you start with prevention, so I ask the doctors, we've trained over 2,000 doctors now from all over the world. I always ask people, have you ever seen an example where people started when they were asymptomatic for prevention, and when they did the appropriate things and they still went on to get dementia? We haven't seen a single case yet. Now, there'll be one at some point, but we haven't seen it yet. If you wait until the second phase, the SCI, we see virtually all these people. And by definition, SCI means you know there's something that's not quite right, but you're still able to score normally on your cognitive testing. That's what SCI is. And it lasts about 10 years. So we really have a tremendous window where we can do so much. And we see when people start at SCI, it's pretty easy, actually. We do the right things, they get better, they stay better. We published a paper a few months ago, first examples showing people who were over a decade with sustained improvement, even though they came in with early Alzheimer's disease. Now, if you wait till the third phase, and that's MCI, mild cognitive impairment, and as one patient said, there's nothing mild about it. It's a little bit like telling someone, you know, don't worry, you only have mildly metastatic cancer. It's a third of 4 stages. In our trial, our earlier trial that we published, 84% of these people showed improvement. But some of them, the improvement wasn't all the way back to normal. Some of them was. We have seen people, this is a score out of 30, a test called MoCA, Montreal Cognitive Assessment. We saw people go from 18, which is very significant, kind of end-stage MCI, early-stage dementia, all the way back to 30. But that's hard. That's not as easy. So the earlier you start, the easier it is, the more complete it is. Now, when people wait until the dementia stage, and by definition that means they've begun to lose the activities of daily living. They may have trouble balancing the checkbook. They may have trouble driving down to the grocery store. They may have trouble with dressing themselves, things like that. We do see people improve, but it's incomplete. And we're trying to understand on the research side, what do we do to take someone who's got a score of 0 and get them all the way back to 30? No one's ever done it, but we've seen them go from 0 to 9, so we want to see what it takes to do that. Again, it tells you, just don't wait. Start as early as you can. The other thing we've seen again and again and again with the thousands of people that have gone through this now, what works the best? Having a well-trained, engaged team is really helpful. And it's just what I was showing you. 4 out of the 6 teams, great stuff. 2 out of the 6 teams, not so great stuff. And then having a diligent patient and supportive partners. The very first people I treated, first woman was actually a woman who worked for the CIA, who actually came through Sandy and her friends, so thank you for that, and came to see me up at the Buck Institute. She has done beautifully. She was 67 when I saw her in 2012. She's now just turned 81. She is currently walking from the Pacific Ocean to the Atlantic Ocean. She's done great. And by the way, go online and check out judywalks.org. Judy Walks, that's Judy. And I saw her in April of 2012. She's still doing great. So, again, get in as early as you can. She's a heck of a walker. All right. So, what she really did that helped all of us. When I saw her, I thought, I'll probably never see her again. She came in, her mother had died of Alzheimer's. She said, I'm having trouble. I'm telling my pets, naming them the wrong names. I'm getting lost when I'm driving. I can't do my job anymore. She'd already been to a doctor back east, and the doctor told her, there's nothing to do. You have the same thing your mother did. And so I said to her, look, we were just starting a trial. Here's the things we were going to do in the trial. If you want to try it, take it back to your doctor. I hope it'll be helpful. So 3 months later, I got a call at my home on a Saturday, and she's like, I can't believe it. My memory's better than it's been in 20 years. So I thought, great. Our research is pointing us in the right direction. And she's continued to do great. She actually went off the program a couple times and didn't do as well, and then she went back on, and she's done very, very well. So her diligence really helped all of us because it helped point us in the right direction, and it helped other people to say, hey, this is doable. So what she's doing now with her huge walk is to show people that cognitive decline can be reversed. And then optimizing the basic 7. We think of this as the basic 7 things. So we like to use a plant-rich, mildly ketogenic diet. This seems to be what has worked best for people. You've got to remember that this is ultimately a network insufficiency. So what you're doing is you're getting people, back to the connection side. You're giving them enough support, and you're minimizing the drag, the inflammation, and things like that. And then exercise, as was mentioned before. Sleep. So how many people track their sleep? Yeah, great idea. So I always check mine every morning. So you want to get at least 7 hours of sleep, as you know. You want to get at least 90 minutes of REM. You want to get at least 60 minutes of deep sleep. And you want to have an oxygen saturation of at least 94% while you're doing it. So if you've got those parameters, you're doing well. But so many people I see, they're sleeping 5.5 hours, and they're getting 2 minutes of deep sleep, and 30 minutes of REM, and their oxygen is dropping to 88%. That's not good. That's not good for your brain. And so many people, sleep apnea goes undiagnosed. The claim from the epidemiologists is it goes undiagnosed 80% of the time. So if you have any question, you don't have to snore to have sleep apnea. You don't have to be a man to have sleep apnea. Anybody can get sleep apnea, even though, yes, more men get it than women, that's fair. And yes, overweight men get it more than others, but still, anybody can get sleep apnea. So good thing to know about. It's pretty easy to check. And so checking your sleep, very good idea. And then stress. Your HR, how many people check their HRV? Yeah, great idea. Really helpful to do that. And getting your HRV up, when there are all sorts of ways to do that, really helpful. And then how many people do brain training? Yeah, good. And actually, the group that we've worked with, Mike Merznick, who's the father of brain training, a wonderful professor from UCSF. We've worked with him for years, and we use their Brain HQ in our trials. They've just shown improvement in yet another trial. So it's clearly something that can be helpful. And then detox. So many of us are exposed, again, from microplastics to phthalates to just on and on and on. And surprisingly, what's turned out to be one of the most common contributors to cognitive decline, we see it again and again and again, and it is mycotoxins. Where, if you're living in a moldy house and you've got exposure to these various trichothecenes and things like that, they actually can hurt your brain. It's, it's not just, it's just mold. It can be a real problem. So that's really important to treat that. And then some key supplements, just as Brad was saying a few minutes ago. So we want to optimize your insulin sensitivity. We see this all the time when people get insulin sensitive, when they become able to go into essentially metabolic flexibility, able to make ketones when they need, their brains get so much better. It's really striking. Getting people, appropriate ketones, sleep parameters I mentioned, getting your cerebral blood flow up, and that's, getting out and exercising. Some people like to use EWAT. Has anyone ever tried EWAT? Do you guys have an EWAT here? No. Okay, but that's a great thing for the future. Really great because it gives you the combination of great blood flow with oxygenation. We've had some people who get much better on EWAT. Mentioned SpO2. The oxygen saturation, oral microbiome. Who's had an oral DNA test? Anyone done that? So that's another good thing to have. Sarah's had one. Okay, great. It's a good idea. This is another common thing. It's interesting. People have been now publishing results looking at your brain microbiome. When I was in school, they said your brain's sterile. It's not sterile, unfortunately. It has its own microbiome, and guess where they come from? It's mostly oral bacteria and some sinus as well. So a lot of what's in your brain as far as microorganisms is coming from here. So if you've got periodontitis, that is an issue. And again, we look for that. It's something that we treat, and it can be very, very important to get best outcomes. Oral microbiome health. I mentioned heart rate variability, gut health, nutrients, hormones. All of these things are important. And don't get overwhelmed. People will say, oh my gosh, this is just too much stuff. Yes, the brain is complicated. Just take it at your own pace. The good news is you have a lot of time to do it. Okay, so just don't let it overwhelm you. Identify and address the specifics. We address chronic infections, herpes, common, P. gingivalis, that's from the periodontitis, babesia, Bartonella. We see this all the time. Tick-borne illnesses. How many people have been bitten by a tick? Okay, so we see this all the time, where you get these tick-borne chronic illnesses, you don't even know that you have them sometimes, and then when you look and see, well, why am I having trouble with my thinking? It turns out that you have them, and treating them really, really helps. Yeah, so, and then the other thing is, don't give up. Just keep tweaking. Just keep, this will really help you to keep your brain working well for your entire life, and that's the point of the book. So those are the main points. And I think the take-home message for all of us is nobody should get Alzheimer's. Don't wait. Get in early. There's so much that can be done. And we're learning more every month. So again, thanks very much to Brad and Sarah and the whole gang. Beautiful place.
Thank you. Just stay up for a moment.
Okay.
First, I want to say thank you so much for all the pioneering work you've been doing. And we were talking beforehand, when people are mavericks and they're sort of busting trail and breaking trail for the first time, as some of us in the room know, they always are the targets for people to go after them. So I just want to publicly thank you for your courage. And in spite of challenges and people that want to look at the world a certain way with a fixed mindset, he keeps trudging on and doing the good work that we all really are grateful for that will help benefit the world. So I want to thank you for that.
Thank you.
Really do.
To say, the thing that gets me up every morning is the emails and the follow-ups from people that actually showed dramatic improvements. I got one from a woman who said, I've started a new life now. I no longer have Alzheimer's. I'm going back to school. I started a new nonprofit. I'm with my kids more. I mean, it was just, so when you get that, you read that, it's like, okay, we really got to keep going, even though you may have a few arrows in your back.
Yeah. Makes you stronger. Yeah. A question for you. Let me start off. If you guys have questions, I'll kick off with the first question, which is, there's a lot of people that, are doing all the right things, and they may say, I'm doing all the right things. I live a healthy lifestyle. Why do I need to get all this testing, and what would I do any differently? And I'd love to hear your response to that.
For sure.
We're in the Bay Area after all, and people are trying to keep fit, healthy, and
yeah. Okay. So here's the reason. Because this is a chronic illness, it sneaks up on you. That has been the problem. So you can see changes. In fact, I'm working with a couple of people right now who are doing very well with their cognition. They might notice a little slip here and there, but basically they're like, yeah, I'm pretty fine. But their p-taus are already high. Their PET scans are already abnormal. They're headed for Alzheimer's disease. Okay, we can head that off. So don't wait. And I would say if you don't want to do the tests, then at least if you have any slips, get in there, because there's so much that can be done. And it's one of these things where, just like other chronic illnesses, the earlier you get in, the better. Now, the problem with, in the 20th century, we mostly died of the simple illnesses like pneumococcal pneumonia and tuberculosis and things like that, and HIV. Now, in this century, almost all of us are dying of complex chronic illnesses. Renal failure and cancers and cardiovascular disease and Alzheimer's, degenerative diseases. And the big difference is you don't get the symptoms until about 80% of the disease is over. That's true for Parkinson's. That's true for renal failure. As you know, you don't get those symptoms until late. So therefore, it's the wearables and the tests that are going to save us from these chronic illnesses. So find out and then do something about it. That's why, again, I just had mine checked recently. I'll have it checked in a couple more years again. And this way you know what's coming and you can do so much more about it.
Yeah, great. Thank you for that. Any questions from the audience? Yeah, great. Start with Dana and work our way back.
Cool. By the way, it seems so typical that you'd be attacked, especially in light of the fact that in the past couple of years, one of the biggest drug frauds occurred in Alzheimer's research. And so this is classic projection. It's not them, it's these outliers. So, but that's not my question. I just wanted to.
Speaking of that, have you read Dr. If anyone hasn't read the book Dr. Fraud, Arrogance, and Tragedy in the Quest to Cure Alzheimer's.
Wow.
Charles Piller, a famous science writer for Science Journal. It is a little boring at times, I'd say, because he goes through, he's trying to do science writing, but oh my gosh, the data are so striking. And
Right.
he talks about just what you were saying,
Right.
the fraud that these guys perpetrated.
Right.
Behind the under-the-table deals.
Right.
Oh my gosh, and they're charging $50,000 a year for these drugs that do not work.
Right.
And they're all based on an outdated model of Alzheimer's treatment.
Yeah, even the committee voted against it, and the commissioner overruled them. So that tells you how much of a take that commissioner was on. Well, anyway, I've done a deep dive recently into aluminum. And what people don't know is there's a big difference between aluminum that we ingest and how a large percentage of that is eliminated and that which is injected, of which very little is actually eliminated. And the FDA gauges the allowable amounts of aluminum in vaccines based on what's ingested. And what's interesting about aluminum is that it's an antiperspirant. And specifically why it's an antiperspirant is that it seals off pores. And when it gets into the brain, I mean, there's a well-known connection between Alzheimer's. So I predict with right now, kids mandated to have 17 different vaccines with aluminum, including that on the very first day of their life with the hepatitis B vaccine. I mean, this is crazy making to the max.
There are so many things that impact brain health. There's no question about that. Thanks, Brad. There are so many things that impact brain health. And so you just kind of looking at these one and another. And one of the interesting things, when I was showing you that molecule, the APP, that goes both ways, one of the things that does is it binds metals, and especially divalent metals like mercury and iron and copper and zinc and things like that. But interestingly, as you know, there's a long history of looking at aluminum as well. Joe Pizzorno, whom many of us know, who's an excellent toxicologist, has pointed out in his studies, yeah, like naturopath, that's right, and he's pointed out in his studies that there is an association of aluminum with cognitive decline.
Great. Yes.
Yeah. So what trials are you doing now? And are there openings for people over 80 to be in the trials? Because we understand that the government won't let people over 80 in trials. Thank you.
Yeah. So we have just one trial going on right now, which is the one I showed you, which is a randomized controlled trial at 6 different sites. But we finished all the recruitment. So it's just right now, it's finishing up the last few months, and it'll be finished end of October. So unfortunately, we don't have any ongoing trials that are recruiting. And in this one, we did go up to age 77. But you're right, we don't typically go. But we do have a lot of people who are over 80 who've had some cognitive changes that have been treated successfully. How many people do you have in that trial? 72. Yeah, let me just say something about that, because people have said, why isn't it thousands? And what they don't understand is it's backward. The more the effect, the greater the impact, the fewer people that you have to have in a trial, which is why with the Alzheimer drugs, they typically have 1,500 to 2,000, because the effect is so tiny that that's how many it takes. We then did the statistics before we started the trial, of course, and it turned out it would take 60 people to show a difference. So we said, okay, let's do 72, which is what we're doing. We've already seen, we could stop the trial now if we wanted to, but it's almost done anyway. We already have a highly statistically significant difference.
So what you might be asking underneath that question is, how do I get access to the ReCODE program if you can't participate in a clinical trial? So maybe you can respond to that.
Yeah, That's a great point. And there's complete access. So the trial is just one little piece of this. And again, most of the others have been, you can have access to it. So a couple things. You can go on My CQ Test. My CQ Test. It's a free test that tells you where do you stand with your cognition. Because we've had a lot of people. Had a woman a few years ago who came in and said, I think I'm okay, but there's some Alzheimer's in my family. I just want to get checked out. Her MoCA score was already only 23. She already had MCI. She was past the first two, but it had come so slowly, and she just thought, well, I'm just getting a little bit older. And no, she really had it. And by the way, she got back to 30. She did absolutely great. So these things are things you want to know about. And so just go on My CQ Test, see where you stand with your cognition. Then you can go on one that's called Get a Brain Scan. Frankly, I wish they hadn't called it brain scan, because this particular one is a blood test. But it combines those three. It combines the most sensitive version of p-tau217, which is the one that when you flip over to that protection side, then you phosphorylate your tau, which is a molecule that normally stabilizes your connections, right? But now you're taking that off, which is why the connections are collapsing, and you're using that to kill bacteria. You make an antimicrobial protein with it. That's what the p-tau is all about. So you measure that in the blood, and then there's a GFAP, which is another blood marker, and then the other one's NFL. That triad together we call brain scan, and we work with a group called NeuroCode that has the most sensitive one. They're the only ones in the country that use this single molecule assay, which Quest is not using, LabCorp is not using, and is more sensitive. And then the other thing you can do is go to just look at like ReCODE. ReCODE is just some labs that are similar to what Brad was talking about earlier that will look at, how's your methylation and how's your inflammation and the critical parameters. So those are all accessible today.
What did you mention, piracetam?
Piracetam, yep.
Because I've used that in the past. Do you recommend that?
Yeah, I don't know the latest data on it. Do you?
There's a trial on levetiracetam. There's a trial actually on levetiracetam, which is a related one. But yeah, there's aniracetam and piracetam and a bunch of these. They have a kind of, as you know, they have a mixed background in that they are glutamatergic. So they are kind of giving you an extra push that in the long run, we talk about, and I talk about this in the book, you want protection and performance. You can get performance without protection. Just take cocaine. You can get, you can get that performance, but we want you to have both. We want you to have performance and protection, and that's where optimizing these things is really, really helpful. So, hydrogene, there are better ways to go, and that was an old one that people used for blood flow. Actually, the one that's emerged and is really supported by the data is nitric oxide, and so people can get. I like to take like super beets, but Neo 40 is good. The super beets, the one negative, has got a little bit of carb in there, which isn't great, but super beets are good, and Neo 40 is good. Some people like Cialis is actually good, and the original work from Cleveland Clinic came out on Viagra. It came out of a screen for all these different things. And like, oh my gosh, people who had that improved blood flow because of that actually had a lower risk of dementia. So what we do is when people have any vascular issues, we use a triad, which is nattokinase, which reduces the clotting. It's arterosyl HP, which improves the blood vessel itself. The glycocalyx, like this, the lining there. And then, of course, nitric oxide. And for many people, that can be very, very helpful.
Yeah, and if you like arugula and beets, those are two good sources in your diet for nitric oxide. Who has questions? Yeah. Great.
How about some of the new novel things that are out there, like cerebral lysine?
So there are hundreds of peptides, and as you probably know, the FDA is cracking down on peptides, so they can be sometimes hard to get, but I think people are pushing back. My hope is that with the current administration, with all the various issues, that there will be more access to peptides, and that was one of the things that RFK Jr. said, and I think that would be helpful. So the key here is a lot of people will approach me and say, what's the latest, greatest, but they haven't done the basics. You really want to have, it's almost like saying, I'm going to build a really cool house on no foundation. It just doesn't work. So you got to get the foundation first, those basic 7. Once you've done that, And by the way, I showed the 6 different sites. Did you notice one of them was better than all the others? That particular one, what they did was they did all the basics for the first 6 months, and then they added some new things after the people were all ready to. Now they're on the right track, doing well. Now they kind of added to there, and they did really well. So yes, cerebrolysin, CMAX, C-LANC, dihexa. You go right down. I happen to like davunitide. Overall, I like the idea of intranasal peptides because they get such good brain penetration. We did some work on this years ago in the lab. Large proteins, it doesn't work. But for little peptides and for glutathione and things like that, it works very well. So no problem. Cerebrolysin has had a little bit of a mixed bag because one of the guys who published a lot of the initial data on cerebrolysin was the one who then was in the book, who actually it turned out many of his papers were fraudulent. And he was working at the NIH, and he got booted. That's kind of hurt cerebrolysin a little bit. But overall, thymosin alpha-1 is another one. Thymosin beta, this is a whole field unto itself. And I think when you've done the basics and for additional things, yes, I think they have real hope.
Yeah, and just to frame the conversation around the basics, so there's a self-care part of the basics, right? So we talked about sleep and movement and stress and what you put in your mouth and connections and relationships. And then there's this chronic disease part that often goes unmissed, this chronic systemic inflammatory disease part, right? So Lyme, right? So tick-borne illnesses and mold exposure, and a lot of times that doesn't get looked at. And then there's the gut health component as well that we talked about. Yeah. This is very much of a functional medicine approach, but the point is that once you can clean all these up, because they're chronically, systemically putting pressure or allostatic load, we call it, they're putting a load on your system, which then your body has to be compensatory around. Then you can add the other things. Once the machine is running clean, and then you put some jet fuel in it and you go, right? So then you can tweak it and really get the benefits. So I really love the site, that clinical site, that was their focus, right? Great. You had a question, right?
So I have a question about the use of therapeutic plasma exchange. I know there was a trial on that for Alzheimer's.
Great point, the AMBAR trial. And so, in fact, we do use that for some people. Now, here's the key. Plasma exchange is a very good way to get rid of toxins. And actually, Dobry Kiprov, you have one of the world experts right here in Mill Valley, Dobry Kiprov. And I've known Dobry for over 40 years. He worked at UCSF when I was there. Really good guy. The issue is it removes, with about 5 exchanges, it removes over 70% of these various biotoxins, even microplastics. It reduces them dramatically. That's all good. However, you have to be careful, and Dr. Neil Nathan, another world expert who's just up the road a little north of here, when you take someone who's very toxic and you detox them too rapidly, they can get worse. And we just had it just kills me. We had a guy just recently who had late stage Alzheimer's, and it had come on really quickly. He was 53 years old. And ApoE4 negative, very, very toxic. And so he went from 7 on his MOCA to 13, was taken care of by Dr. Christine Burke, who's an expert out here in Sacramento. Then we thought, okay, this guy has such a heavy toxin load, we really have to get him to plasmapheresis. And I asked Dobry, can you kind of space these out because this guy is really toxic? He said, that's not the way we do it. We do 5 within a few days. This guy went through this, bam, and it was almost like, imagine someone who's living in alcohol toxins for years, and then you suddenly take away the alcohol. You know what happens. It's not a good thing. So this guy, after he went through all these plasmapheresis, he had a few days, and then suddenly he was irritable and angry and aggressive and throwing things at his mother, who was trying to help him. And his family just said, we give up, we're not going to do anymore. So it kills me to see that, because he was on his way getting better, and he got we believe. Now, I can't tell you, guarantee that that's what happened, but that's the worry. So I think that we have to just be careful. For the vast majority of people, plasma exchanges can be so helpful. We have toxin exposure to all of us. But the more toxic you are, the more careful you should probably be. The other thing that I really like, I don't know, Brett, if you like PCIV, the PK protocol with glutathione and phosphatidylcholine, this is another good way to reduce the toxins. I'm wondering now, could we combine these? Could we kind of get, one is more supportive and one is more subtractive? And maybe we do these intermittently together. So there's a lot, just as you said, there's a trial. The AMBAR trial did show some improvement, but there's still a long way to go, and we need to keep optimizing that approach because I think it'll be important for the future.
Great. One, maybe two last questions. We just have a few minutes left. Okay. I will say the glutathione I've done nasally, and it's hard to do. It's sort of like shocking to your system. Yes.
Hi. So less scientific question, and forgive my naivete, but this is so wonderful to hear, and I'm curious, you had mentioned that there's pushback or keep going despite the arrows in your back. What's the controversy? What's so controversial about the study?
Yeah, and when we started this, I was very naive as well, and I thought, like, okay, we can make people better for the first time. Don't we want to do this? We don't know how many, we don't know what it's going to take. We've learned a lot in the last 10 years, now 13 years since I saw Judy. The pushback has been, number one, this is something we haven't seen before. We're using drugs, and you're interfering with that. Number two, the pushback has been, we don't believe it yet. So one of the guys, they did a really nasty article on the front page of the New York Times just a few months ago saying, I'm this horrible person making these claims. And the guy said, the expert that they asked said, there's no proof yet. And I said, what about the data? So I had worked with this reporter who did this story for 8 months. I sent her everything you saw times 100. I sent her the data from our trial. I sent her our earlier trial. I had her talk. I said, look, I won't work with you unless you talk to a dozen different people. She talked to doctors. She talked to patients who'd gotten better themselves. And they all said, oh, this has helped me. She left all of that out. She didn't put a single thing that I had told her in the article. And she just wrote, this is horrible, this shouldn't be done. And she found, on her own, she found one patient who started in the end stages, did this for 8 months and gave up. And she said, see how bad this is? So, so here are the data. We have data on imaging. I showed you one of them. We have data. We showed improvements in volumetrics. We have electrophysiological data, quantitative EEG, evoke responses. We have improvements in things like basic health. We have improvements in cognitive tests, multiple cognitive tests, published trials. Another group in San Diego published a trial just like ours right after we did, just confirming everything we saw. So we have, we have a ton of data, but the argument is we don't believe it yet. So okay, this happens. If you go back to scurvy. So when people were dying of scurvy, on ships and stuff, do you know that they had a solution for this in the 1600s, the 1700s, the 1800s, the 1900s? And each time the experts would say, nah, we don't believe that. And so that then it would go away. And then and people would be dying of scurvy. Then they would come back and say, oh, we now do have something. And they keep on going away until they finally figured out, oh, it's vitamin C and you can take citrus and stuff like that. But we doctors have a bad history of being not very innovative.
There's a conversation of if your pretest probability is low, then it requires much more proof in order for your post-test probability to say, oh, that indeed is something. So we classically do this for blood clots. If you're a pretest, you come in the emergency room, and if you have a very low pretest as a clinician probability that this is really a blood clot, you require so many tests to finally treat someone with an anticoagulant to treat them for their blood clot. If you think it's a high probability, like you just had surgery and then you got on an airplane and you drove all day and now you show up here and your leg's swollen, I don't need much to put you on an anticoagulant. And so you come in with biases, and depending on, and no, everyone pretends they don't have a bias, but we all do. And when you review the data, if you come in with a bias, even though you're looking at data and you're a scientist, it completely influences what you believe on the backside. So that's, yeah.
Thank you for your time. Coming at this from a lens of a personal trainer, have you seen, getting back to optimizing the 7 basics, have you seen a direct correlation between any of the directs of those basic 7s that play a bigger role than any other, especially when looking at my clientele base? I have individuals who kind of fall within the standard deviation who are good with 3 out of the 7 or 4 out of the 7. And of course, a client here who's with me who's an outlier who has a 7 all down. And then on the opposite end, an individual who's going to do 1 out of the 7. So with having conversations with clients, it'd be interesting to hear what your research and data points to with those basic 7.
Which one of the 7 should you do?
Yeah, and we hear this all the time. What's the one thing you should do? So, yeah. But here's the key. You go back to, we understand the science better than we ever did before now. In fact, we understand much more about things like, why do you get prions? There are prions associated, discovered right here at UCSF and led to the Nobel Prize for Dr. Prusner. We understand much better why all these diseases have prions at their center now. And if you look at these diseases, what they really represent is network insufficiencies. You have a network, it doesn't have the support it needs, and so it has to contract, basically. So you now want to fix that. You want to improve the supply, reduce the demand, and so, yes, exercise, all these things. Now, which one's most helpful? What we've seen again and again, although they're all helpful, to be fair, what we've seen again and again is metabolic flexibility, getting you so that you can be insulin sensitive, but you can also generate ketones when you need to, and getting people above a ketone level of 1 or 1.5 millimolar BHB at least once during the day. That combination is very important and really does help. This is a brain energetic failure. As you can see on that ASL scan, you don't have the blood flow. That, the signature of Alzheimer's on a PET scan is reduced utilization of glucose. You're not using glucose right in your temporal lobe and your parietal lobe. So I would say if you had to pick one, it would probably be your metabolism, nutrients, but exercise, absolutely critical. And as Brad mentioned, what had been shown years ago is regular exercise has the same magnitude of reduction as 1 copy of ApoE4. That's the 30% that he mentioned. The 90% is a little more, so you have to do more. But again, if you have 2 copies of ApoE4, don't worry. That person I showed you today had 2 copies and already had MCI, and he did great. So get in early. And so, yes, stress is also important. Sleep is also important. I would say if you had to pick 3, it would be those. It would be nutrition, exercise, and sleep. Those are probably the biggest ones.
And just to clarify and to conclude, because I want to keep to our time. So what you're saying is they don't use glucose well, and you could see that on those scans. And so what you're saying, therefore, is if your beta-hydroxybutyrate, BHB, he was talking about, levels are up, your ketones are up, so you're fasting typically to get that, or your ketogenic diet, meaning that you're eating very little carbs and only modest protein and a lot of healthy fat. If you're doing one of those paths, timed eating, we call it, then you're able to generate ketones, and then that preferentially is used as fuel in the brain. Is that what I'm understanding?
One key caveat. So, as you mentioned, you go back and forth, ketones and glucose. And so there's an important trick to remember here. This is a network insufficiency. So if you are already frail, so I worry about the people when they drop below 20 on the BMIs. So if you're frail, do not try to get yourself into ketosis right away. You starve yourself and you hurt yourself, and people we see go backwards. So at the beginning, I just say, look, for the first month or 2, just take some exogenous ketones. That'll give you. Professor Stephen Kinane from Canada did some beautiful work showing just giving people with MCI ketones, exogenous ketones, made them better. So that's at least a beginning to get you that influence. I notice myself sometimes if I get up and I'm like, oh, I'm not feeling up to snuff. I'm like, okay, if I take a little ketone, I'm like, whoa, it's a little bit like an Adderall or something. It really, boom, you get that focus. So be careful about that. The other thing is, has anyone looked into UCAN at all? UCAN, have you seen this? This is a fascinating new approach where it's essentially a larger starch that was made. This was made for people with mitochondrial dysfunction, true mitochondrial genetic disease, where they literally couldn't go the night because they couldn't, they basically couldn't break down. These are people who have glycogen storage diseases where they just can't even break it down, so they become extremely hypoglycemic and die as babies. So they developed this super starch, which has come out now as a product, UCAN. And what it does is it just gives you very small amounts of glucose throughout, for hours. And so Judy is actually using this on her walk across the country. It's a nice way to get slow energy, essentially. You don't want to overdo it, but for times where you're worried about being hypoglycemic, it can be very, very helpful, and it certainly helps the babies. So that's the one thing. Be careful about trying to push yourself into ketosis if you're frail. It actually is easier, as you know. People who have a few extra pounds and a little extra fat, they are easier to treat because they can generate the ketones from their own adipose.
Yeah, that's great. Well, thank you so much, Dr. Bredesen. Round of applause. Yeah, and for those, so we do this quarterly, so we'll invite you guys again to come back. We'll post this on YouTube for those that couldn't be here live or come here live in the real world. So thank you very much again, and have a great evening.